We're good.
We're good.
I mean, digital
Okay.
cameras do nice pictures, but they have that hesitation.
Well, good evening, and thank you for coming. Appreciate you spending some time with us so that you can learn a little bit more about sleep apnea and the options for treating it. I'm Dr. Joel Nathanson. I'm a dentist. I've been a dentist for longer than I can remember, but recently, for the past 5 years, I've been treating sleep apnea using oral appliance therapy, and I'm going to talk a little bit about that. But first, for anyone who would like a little bit more background, a little bit more information on sleep apnea, I'm going to go through a few facts and figures and such. I'll probably be telling you a lot of stuff that you already know, a lot of you. But if you do glean a few facts, then that's great. If it's something that helps you to understand the condition better, that's what this was for. Okay, and so away we go. Dental Sleep Medicine 101. Healthier Sleep Solutions is actually the entity through which we treat sleep apnea. Healthier Sleep Solutions it's not so much a part of the dental practice as it is we share the same space. Healthier Sleep Solutions is a DME company, a durable medical equipment company. We are certified through Medicare as a DME provider for Medicare. We did go through that process, and so we do oral appliances as Healthier Sleep Solutions. Nancy, could you get the light? It's the second one from this
Absolutely.
right there. So there's a little bit of glare on the screen here.
Other one.
There we go.
Yep.
Thank you.
You're
Okay.
welcome.
Can you still see me?
Can still see you.
Can still see me. Okay, good. All right. Well, a lot of people come to treatment for sleep apnea because of this, snoring. Okay, snoring occurs because the airway gets partially blocked. Many people who have sleep apnea do snore. Many people who snore have sleep apnea. In fact, 70% of people who are loud snorers do have some degree of sleep apnea. Many times, snoring is the first sign that there is a problem. Many people accept snoring as just a fact of life. It's a lot of times it becomes something on cartoons where we see big Z's above the head on a character or such. But snoring is actually a partial obstruction of the airway. When somebody is snoring, they're not breathing as clearly as they should be. So let's talk about normal breathing. Normally, air passes through the nose, past the structures in the throat. You can see up there that nice blue line there where it's a nice clear area. So that's normal breathing. However, when somebody snores, this part of the throat here starts to vibrate. That's what creates the snoring sound. And as you can see, it's blocking the air. The air is not getting through quite as well. However, in the case of obstructive sleep apnea, it's totally blocked. It's either the base of the tongue or the palate or some combination of that blocks the airway. And that's why people have this kind of condition here. Often snoring will progress to obstructive sleep apnea, but they don't always come together, but they usually do. So this is the vicious cycle of sleep apnea. If a person has sleep apnea, they go to sleep, that's what sleep onset is, then their airway collapses. Then the apnea, they can't breathe. Apnea is the complete cessation of breath, or the 90% blockage of the airway. So when a person can't breathe, the oxygen goes down and the carbon dioxide goes up. And so there's more effort to breathe, and sometimes they can open up the airway through this increased effort, sometimes they can't. Sometimes they have to wake up, which is what arousal is, and then the airway opens, the person hyperventilates, and the whole cycle starts over again. And this can happen all night long. This can happen hundreds of times a night in the case of sleep apnea. But this is the cycle, and this is the science and the physiology behind it. All right. Whenever I talk to somebody about sleep apnea, very often they'll say, I'm fine. I sleep just fine. It's just that I'm tired all the time. Well, if you're asleep, you don't really know whether you're sleeping fine or not, quite honestly. This gentleman here is in a sleep lab, and let's see if this video can work here. Okay, so he's breathing. He's struggling to breathe now. And then he'll quiet down a little bit. Okay, so he's not breathing now. I'm going to time him. It's 5 seconds. Now he's trying to breathe. 10 seconds. He's trying to breathe, but he can't get a breath in. 15 seconds. 20 seconds. Still trying. 25. Still trying, can't get that breath in. 30 seconds. There he goes. 32 seconds. He finally can breathe. But for all that time, he wasn't getting any oxygen into his system. And he's about to go into another episode. I'm going to spare you the sign for that there. So obstructive sleep apnea is one of the most common sleep disorders. It's very, very widespread. And the fact of the matter is that 90% of the people who have it don't know they have it. That's what makes it so dangerous. I talked about apnea being a 90% blockage of the airway. A hypopnea is a partial blockage of the airway. You can still get air through, but it's like trying to breathe through one of those little coffee stirrers. You're still getting some air through, but it's not enough. And the oxygen level in your blood is still going down. So untreated obstructive sleep apnea can take 12 to 15 years off your life. That's actually more than smoking. So even if you have a CPAP where you're using it, that's something that's better than having untreated obstructive sleep apnea. Type 2 diabetes takes 5 to 10 years off a person's life, and there was a study done in 2009 saying that obstructive sleep apnea increases the risk of death by 46% from cardiovascular disease. So you can live for 3 weeks without food, you can live for 3 days without water, but you can only live 3 minutes without oxygen. So, how common is it? Like I said, 90% of the people who have it don't know it. The 90% is that red circle. That's how many people have obstructive sleep apnea that don't know it. The little wedge here are the people who've been diagnosed with sleep apnea, but very few of them have been treated successfully. Only about 25% of the people who have sleep apnea have been successfully treated. And by successfully treated, that means they're using an oral appliance all night, every night, or they're using a CPAP all night, every night, or they've had surgery to open their airway and they can breathe properly. Only 25%. So this big red circle is what we're going after by having this kind of a talk, because people can recognize themselves sometimes in the symptoms that they see. Okay, sleep disordered breathings increase with age. Sometimes it's snoring, sometimes it's gasping during sleep, sometimes it's neither one of those. It can be very quiet and have sleep apnea. Neck size is a very great predictor of obstructive sleep apnea. If a person has a large neck, even if they're very muscular, okay, a lot of professional athletes have sleep apnea because the muscles on either side of their airway and their neck are so well developed that they crush into the airway. It has nothing to do with what good shape you're in. Okay, it has nothing to do with how much you exercise. It increases with weight, although there are some people, if a person is very thin and has a very small neck and a very small airway, that can get easily blocked. that's a person who's highly at risk for obstructive sleep apnea. Us guys get it more than the girls. So, and the tonsils, adenoids, the tongue, if a person hasn't had their tonsils out, they're very much at risk for obstructive sleep apnea. When I was growing up, everybody got their tonsils out. I mean, it was kind of like a rite of passage. I remember in 4th grade. Then the pendulum swung to the other side where nobody was getting their tonsils out. It was very rare. Now it's sort of swinging back towards the middle where sometimes they're getting them out, sometimes they're not. It really depends on the size. But the tonsils very, very often are implicated in obstructive sleep apnea. Hypothyroidism, coexisting cardiovascular disease, allergies, and a family history. Okay, many times when I talk to people about sleep apnea, they say, oh yeah, my dad had that, or my grandfather kept us all up snoring. So we know a lot more about it now. Okay, so here's a little game for you. So guess which one of these people does not have sleep apnea?
The young doctor on the left.
The young doctor on the left. Which one is that? So, well, it's actually a trick question, okay? When I made this slide and first did this presentation, I did not have sleep apnea. I now do. I have mild sleep apnea. So, but the point of this is, I mean, this fella here, you know, Anthony, my friend Anthony is one of the best, you know, physical specimens I've seen as far as somebody who keeps in shape. You know, he does like, you know, P90X and, you know, the resistance training, you know. He's always trying to get me to do that stuff. And I say, you know, I told him you do enough for both of us. So, but he's in great shape. But he has, it's almost moderate sleep apnea. He has the number of events that he has. You see, he has a very slender neck, and like I said, a lot of times, even when the muscles are very well developed, it can, you know, push in on the sides of the airway there. Shaq is his sleep test was actually a 60 Minutes episode. He did a home sleep test as a 60-minute episode, and he was diagnosed with sleep apnea. And this was at the height of his career. When he was running up and down the court, he was in great shape. Okay? But look at that neck. He's got a huge neck. And so the airway gets crushed sometimes. So the most common symptoms for sleep apnea are snoring, excessive daytime sleepiness, you know, where you just need that like 8th cup of coffee to keep you going. Hypertension, high blood pressure, very, very common to have obstructive sleep apnea if you have high blood pressure. In fact, if a person snores and has high blood pressure, there's a very, very high percentage, very high probability that they have obstructive sleep apnea.
I better go.
Okay, and if you put diabetes in the mix, then it's better than 90% of people who have the 3 of those have some degree of obstructive sleep apnea. So other symptoms, we're going to go over these really quickly, but people with acid reflux, morning headaches, diabetes, sexual dysfunction, social problems, memory problems like Alzheimer's, dental symptoms. If a person's teeth are really worn down, I always ask them about, you know, have they ever been checked for sleep apnea? A lot of times they have, you know, they have it. And so obesity and large neck circumference contributes to it. Menopause, very interesting. Before menopause, the ratio of men to women that have obstructive sleep apnea is 7 to 1. After menopause, it's almost 1 to 1. So there's that change there. And mouth breathing dries out the tissues and such, makes it more likely that a person is going to have trouble getting the air through there. So excessive sleepiness, a lack of energy. Every time you experience an episode of sleep apnea, it's like waking up a little bit. Okay? So you may not remember it. In fact, most people don't remember it. But think about that. If you were trying to sleep and somebody kept poking you, waking you up like every 10 seconds or every 5 minutes even, okay? How well would you feel at the end of the day? Well, people who have obstructive sleep apnea, they have that every single night. It's a disrupted pattern of sleep. When we sleep, we go through different stages of sleep, the different brain waves. And the really deep sleep is what regenerates our bodies. People who have obstructive sleep apnea spend very little time in that regenerative phase of sleep. So, excessive daytime sleepiness is not only dangerous to you, it's also dangerous to those around you. Tired driving is actually more dangerous than drunk driving. It claims more lives every year than drunk driving. A study was done back in 2003 where they compared people's reaction times in driving to what it was when they had certain blood alcohol levels. If you have 4 or less hours of sleep per night, that's the same as being legally intoxicated. 0.08 is the Maryland level for intoxication. And if you sleep 4 hours or less, it's like being 0.095. So this is something that's really quite a problem in a lot of cases. This fellow here, see his eyes just closed? This is a drive cam that's in his taxi. This is a taxi driver. This is a fellow who drives for a living. And he's in a crash. And so that's not only an advertisement for not driving while too sleepy, it's also an advertisement for wearing your seatbelt.
He was trying to get in the back seat so he could get
Take
some
it out.
rest.
Yeah, well,
Pulled over first.
yeah, he got back there, but a lot faster than he thought he was going to. So, in 2009, tragedy in southeastern Utah, there was a bus driver who had a crash, and they looked at the video camera that was on the bus, and the passengers were all obviously reacting to the fact that the bus was about to crash, and the driver's expression never changed. He was asleep, literally asleep at the wheel. 9 people died in that accident, and 50 were seriously injured, all because of untreated sleep apnea. It's a killer not only of the people who have it, but of those around us. So, high blood pressure is a symptom because every time you wake up with an event with obstructive sleep apnea, your body experiences that fight or flight. Okay, when you can't breathe, it's like somebody's choking you. Okay, so you react. Your body reacts. It says, I got to do something about this, and so that adrenaline starts squirting. Your blood vessels narrow, and all that. So that's going to raise your blood pressure. Okay, having obstructive sleep apnea raises the risk for high blood pressure by 45%. Acid reflux. That video that we watched before of the man in bed where he was like trying to breathe, when he makes those motions, he's bringing his stomach in, trying to, get his diaphragm to push his lungs to open his airway, and when he's doing that, he's pushing up the contents of his stomach as well. So that's why you get GERD, the esophageal reflux from obstructive sleep apnea. Migraine headaches. If you have higher blood pressure, if your blood vessels are being constricted, you're not getting enough oxygen, that can cause headaches, and they're usually associated with the lowering of oxygen in the blood, these headache events. Diabetes. Obstructive sleep apnea has been linked to causing problems with the endocrine system, with the glandular system, which includes the glands that process insulin. So diabetes can often be a sign of obstructive sleep apnea. Okay. Sexual dysfunction. One of the things about oxygen is, besides the fact that we all need it to live, okay, when the body gets enough oxygen, it creates what's called nitric oxide. That's a natural vasodilator. It opens up the blood vessels. That's why if you don't have it, you get higher blood pressure. Well, if you sleep well and you get better oxygen, it does the same thing that Viagra does. It opens up the blood vessels that, enable that area of the body to be nourished. Without it, the blood vessels still constrict. So all these things, if you have any of these symptoms, please get yourself checked for obstructive sleep apnea if you haven't already done so. An interesting thing in here, the reason I put this slide in is that obstructive sleep apnea lately has been linked with Alzheimer's disease. And I was at the American Academy of Dental Sleep Medicine meeting in Boston this past summer, and they came up with a possible mechanism for how that occurs. When we go through our day, our brains function and the cells create waste products called beta amyloids. When we sleep, especially during the stage of sleep that's called REM sleep, the rapid eye movement sleep where people dream and you have all these dreams about chasing a donut across the George Washington Bridge or something like that. You have the really strange dreams. But during REM, the fluids that are in the brain, they sweep the beta amyloids out. So if you don't have enough REM sleep, you don't get those swept out. Alzheimer's patients have a significantly elevated level of beta amyloids in the fluids in their brain. So, possible causal mechanism there. But the big killer with obstructive sleep apnea is cardiovascular disease and stroke. The problems with the blood pressure, the problems with having the extra adrenaline in your body. When you're sleeping and you have 10 events per hour, it's like running up a hill 10 times, and it takes the toll on the heart, and over time that's what causes people to have these kinds of diseases and eventually die from it. People don't die from sleep apnea. You don't stop breathing 20 times and only start breathing 19. That's not how it works generally. Usually it's the problems that are caused by sleep apnea that shorten a person's life. So only two or three of every 100 people that have this have been successfully treated, and 90% of them haven't even been diagnosed. So I think this is unacceptable. When I heard about this, I said, this is something that I have to do something about. So what we did, like I said, I love technology when it works. Okay, so now that I've told you all the gloom and doom about obstructive sleep apnea and how it's, the work of the devil or, whatever, but...
now I think I have it, but okay.
Well,
I'll find out.
this next part, please listen carefully during this next part. This is for you, okay?
Okay.
Assessment and diagnosis, okay? The very first thing that you need to do, and we can actually do this for you today,
Okay.
is to be screened. And screening is a very simple questionnaire that we will have you fill out. We ask you things about daytime sleepiness, okay? There's actually a scale called the Epworth scale that a lot of insurance companies use as their determining factor. Does this person, or is this person at risk for sleep apnea? Okay, it asks about your degree of sleepiness in various situations, okay? Another diagnostic screening is one that we use called the adjusted neck circumference. Okay, like I said, neck size is a predictor of obstructive sleep apnea. There's research done where they said if you take the person's neck circumference in centimeters and you add in certain numbers for high blood pressure, for times that they've been witnessed stopping breathing or wake up choking and gasping, if they have diabetes, if they have AFib. Okay, this adjusted neck circumference is a very, very good predictor as to whether somebody is going to test positive for obstructive sleep apnea. But the screening, whether it's this form, there's another form that's called the stop bang form. There are tons of forms out there for screening for obstructive sleep apnea. Several, like the stop bang and the Epworth, have been noted for years as kind of the go-to questionnaires for screening. So that's the very first thing. We have all of our patients fill out one of these forms as a dental office, not even for sleep apnea, as a dental office. And we've picked up a number of people who were at risk for sleep apnea, had no clue. And they got tested. A number of them tested positive, and we were the first indicators that they might have a problem with this.
Now, let me ask you a question.
Sure.
Do you use anything for? See, I had a test once, and it was mild, and they told me I didn't need anything. But that was maybe 4 or 5 years ago.
Yeah, like I said in the presentation before, it increases with age. Okay, that's a that's a risk factor. If there have been any changes in your weight, that's a risk factor. When somebody says that you have mild sleep apnea and you don't need it treated, I have an issue with that personally. Okay, I think that if a person,
because that's what the study center said, or whoever,
right,
wherever I went.
Well, it's not for me to argue with another physician. Everybody has their own opinions on this.
Well, my father had it. That's why I'm concerned.
You have a family history. Okay, so you have another risk factor. Okay, so the question is, if you have a condition and you don't treat it and it gets worse, then should you have treated it before? Right. That's the question I would ask. Okay, and we're going to get to what mild sleep apnea means. Mild, I put mild in quotes, what that means in just a minute. That's in another slide or two here. Okay. So we'll talk about what that means. So, okay, so let's say somebody fills out one of these screening forms and it says that there's a fairly good probability that they, are at risk for sleep apnea. Okay, the next step is to be tested. Okay, now when I first started this about 5 years ago, screening my patients, and I said, well, you really should go for a sleep test. And they say, well, I don't want to go to a sleep lab, have somebody watch me sleep, have all those wires taped to me and all that stuff. And so sleep testing has come a very, very long way. First of all, a lot of times you can do a sleep test at home. Okay, several of these devices here, this one here that fits on the head, this one here that goes, you see, he's at home. He's with his well, I was going to say his wife, his bed partner, whoever that is, okay? I know who that is. So, that's another home device up there. This one's in a lab, okay? But I put this picture, I actually did one on myself. That's how I found out that I have mild sleep apnea, because I had been tested years before using this device, and I didn't have sleep apnea. But that was 5 years ago, and I had the opportunity to do another one here. So, and it's very easy to put these on. Okay, even a dentist can do it. So, and these home devices, they're actually very good, and they're quite accurate. The studies have shown again and again that home sleep testing can give you at least your first level of diagnosis. Now, going to a sleep lab is, that's the gold standard. Okay, that's the state of the art. That is, you have somebody, a certified respiratory technician that's helping you with the equipment, making sure that it's on properly. They're making sure that it's staying on properly. They're monitoring the, it's like, I don't know, it's somewhere between like 13 and 20 different parameters. The home sleep tests only measure something like between 4 and 7, most of them. A couple of them may do a little bit more than that. But the thing about doing a home sleep test is that you're looking at fewer parameters, but it's a more normal night's sleep for you. You're in your own bed. You're with your bed partner. It's a more normal night's sleep. So they're not measuring quite as many things with it, but it could be more representative of what your sleep usually is during the night, okay? And very often what they'll do is they'll have you do it for 2 nights, because getting used to it is, you may not sleep so well the first night, and then the second night it's a lot easier. So it's more natural. People are more used to it. So, okay. So here I'm going to talk about what they'll look at on a sleep test. Okay. Like I said before, obstructive sleep apnea has 2 types of events. The apnea, it says 100% flow limitation for at least 10 seconds. That's actually not correct. I have to fix that slide. Sarisa, please remind me. Okay. It's actually 90% or more flow limitation. Okay. So it's just about completely stop breathing for at least 10 seconds. A hypopnea is a partial airflow blockage that has a decrease in the level of oxygen in the blood. Here it says by at least 4%. There are some that look at it 3%. And again, it depends. Medicare has one standard. Blue Cross Blue Shield has another standard as to what they consider to be an event. But it's the oxygen being lowered because you can't breathe as well. That's what it is. All right. So, but the reaction of the body to a hypopnea, to the partial blockage, is the same as to a total blockage in most cases. If it's down 3%, 4%, whatever you want to say, that can happen with an apnea or a hypopnea. So what they do is when you're tested, the machine can tell how many of these episodes you have, how many apneas, how many hypopneas. And so what is done is the total for the night is noted, and then it's divided by the number of hours that you slept. So it's the total number of apneas or hypopneas that you had per hour during the night, and you get a number that's called the AHI index, the apnea-hypopnea index. Okay, so if it's 5 to 15, it's considered mild. If it's 15 to 30, it's considered moderate. If it's 30 or more, it's considered severe sleep apnea. Okay, so when they say you have mild sleep apnea, that means that at least 5 times an hour you are having a blockage of your airway that's making your oxygen level go down at least 3 or 4% for at least 10 seconds. At least 5 times an hour. It could be as many as 14 or 15 times an hour that's happening. So again, I would have to look at your study and look at your numbers. And again, if it was a while ago,
Yeah, it was a while ago.
okay, so you probably should be retested. Okay, if you have any degree of sleep apnea, you probably should be retested, every few years, just to see where you are and to particularly if you're not having any treatment for it. Okay, if you're being treated, then that's a different story. Okay, but this picture here, I always want to talk about this picture under the severe sleep apnea. That gentleman there, well, it's a bust of Reggie White. Does anyone here know who Reggie White was?
Green Bay Packers.
Green Bay Packers. That's right. Yeah, he was the Minister of Defense. He was the Defensive Player of the Year. I think it was in 2000. I'm not sure. He died from the consequences of severe sleep apnea, and that's his wife. At when he was inducted into the Hall of Fame in Canton, his wife started the Reggie White Sleep Apnea Foundation to spread the word about this condition, so that other people wouldn't have to go through what she's gone through. So treatment. So you have your diagnosis, you've been screened, you've got your diagnosis. Treatment options, okay? CPAP. CPAP is the most common type of treatment for obstructive sleep apnea. And as you know, those of you who have CPAPs know, it blows air into the airway, and that's how it keeps it open. And CPAP is 100% effective when you wear it. When you don't wear it, it's 0% effective. And a lot of studies have shown that there are many people who get CPAPs that for one reason or another can't wear them. They feel claustrophobic with the mask, although there are several different types of masks. So if one doesn't work for you, try another one. Because again, there aren't many things in medicine that you can say are 100% effective. The CPAP is, when you can wear it, okay? So that's the CPAP, but it works only if you wear it. Okay? And the Darth Vader helmet, and I have a lot of patients who say, that the noise keeps them awake, the noise keeps their bed partner awake. There are, different kinds of masks. Like I said, if a patient has had some success with CPAP, but they don't like their mask, I encourage them to try another mask because there are a lot of different ones. But then there are the people who just can't wear a CPAP. And for them, we have the alternative of an oral appliance. Okay, this young lady is showing the difference between a CPAP mask and an oral appliance, showing that it's a lot smaller. Okay. The reason that we can do oral appliances to treat obstructive sleep apnea goes back to a statement that was made by the American Academy of Sleep Medicine. These are physicians now, not dentists. These are physicians. Back in 2006, they said oral appliances are indicated for use in patients with mild to moderate OSA, obstructive sleep apnea, who prefer them to CPAP therapy, or who do not respond to, are not appropriate candidates for, or who fail treatment attempts with CPAP, and should be completed by a dentist with advanced training in sleep medicine. Okay? I have had over 150 hours of continuing education in dental sleep medicine. It's something that I've dedicated my professional life to. And so there are, patients who, they go to their dentist went to a weekend course, or they read an article in a magazine, and there are appliances out there which are kind of like, they come out of the box, they're boil and bites, stuff like that. I get very, very uneasy when I hear about these things because those are not proper treatments for obstructive sleep apnea. The appliances that have been recognized as effective against obstructive sleep apnea are, there are many different types, okay? But the three most used are called the TAP appliance, the Herbst appliance, and the dorsal fin appliance, okay? I'll talk about the dorsal fin first because that's got the name that's the most fun, okay? It's you see it's got this little fin there. It looks like a shark's fin, okay? That's a piece that is worn on the lower jaw. The upper jaw has a block that goes behind that fin, and what it does is it positions the lower jaw forward. All of these appliances basically do the same thing. They position the lower jaw forward, and I'll show you in a diagram how that works in just a second. The Herbst appliance, again, it does the same thing, positioning the lower jaw forward. It has these bars that are on either side that hold the lower jaw forward. The TAP appliance, which is the one that I use the most, it has a hook on one piece that fits into a slot on the other piece. And the hook can be brought further forward, like 1/4 millimeter at a time. In fact, all of these are very, very, they're very sensitive to adjustment. They can, the dorsal fin, there's some dorsal fin appliances that you can adjust in 1/10 of a millimeter. they're what are called titratable, which is the problem with a lot of the other appliances I was talking about before that you just come out of the box. These are custom made by qualified labs, and they can be positioned so that the lower jaw can be brought forward by degrees, okay? Because you're pulling on the jaw joint here, okay? You don't want to end up with jaw joint problems. It's another reason why a qualified dentist needs to be making these appliances. So the TAP appliance, TAP is a Thornton Advanced Positioner, or anterior position. Well, the T is Thornton. Dr. Thornton invented it. Okay, and so the dorsal fin appliance would be for somebody who can't tolerate having their jaws together. Okay, that's the only reason to use a dorsal fin appliance. Well, I shouldn't say that's the only reason, but that's a reason to. Most people that get the TAP appliances that we make adapt to them very, very easily. Okay, there's an adjustment period like with anything. Okay, but they adjust to the TAPs very easily. I wear a TAP. Okay, that's the appliance that I use, and I'm at the point where I sleep better with it than without it. There have been times when I've gone to sleep. I don't know if I'm like really tired or and I wake up during the night and I'm feeling like, where's my TAP? So I go into the bathroom and I get it and I put it in and I go back to sleep. So the way that these appliances work, okay, so again, I showed you before the diagram of normal breathing, okay? When the palate or the tongue goes against the back of the throat, it creates the snoring, it creates the blockage. That's the sleep apnea issue here. What the appliance does is it brings the lower jaw forward, which brings the tongue forward, which brings the base of the tongue away from the back of the throat. That's when it works, is that it tightens up to hold the airway open. It provides what's called pharyngeal tug. It tugs on the pharynx, the airway, and it helps to open it up that way. So that's how an oral appliance works, and in the case of mild or moderate sleep apnea, it can be a first line of treatment. Even in severe apnea, if a person does not want to wear a CPAP or they can't wear a CPAP for some reason, an oral appliance can be effective. There have been studies that have shown that even in cases of severe sleep apnea, an oral appliance can be an effective treatment for these patients. Okay, so that's the message that I would like to have everybody take home. If you have any of those conditions, like headaches, diabetes, erectile dysfunction in the men, daytime sleepiness. If you've experienced any of these things and nobody has ever talked to you about the possibility that you might have sleep apnea, please feel free to give us a call, talk to your physician. Please get this treated, because it'll take years off your life. It'll make you a danger to the people around you, and when you get it treated, your life is just so much better. The most critical thing is getting yourself screened immediately if you have any inkling that this might apply to you. Screenings lead to more patients being diagnosed and successful treatment, which is the main thing that we're looking for here. So I want to thank you for listening to me ramble on and on about this. I hope you can tell this is a passion of mine. When I started treating this, I saw the difference that it made in people's lives to get something, especially the people who tried and failed with CPAP. They felt like there was no hope for them, okay? Or they would wear their CPAP for part of the night and then they'd tear the mask off. The only way it can be effective, any treatment can be effective, is if you use it all night, every night, okay? Standards of success with CPAP, many times they'll say, well, if you wear it for 4 hours a night, 4 days a week, that's considered success. Well, what about the other 3 nights of the week? What happens then? That's, or the other hours that you're not sleeping. I would prefer that you have something, the oral appliances depending on the studies, what studies you read, somewhere between 70 and 85 to 90% effective when they're done properly. Okay, so it's not 100% like a CPAP, but if it's something that you're going to wear, and people usually have a much easier time getting used to an oral appliance than a CPAP, even though CPAP is more effective. But if it's something that you're going to wear, then that's what you should use. Okay, there was a study in India, a 7-year study, where they followed 2 groups of people, one on CPAP, one on oral appliances, and the degree of what they called disease alleviation, where they looked at how many people had strokes, how many people had cardiovascular disease, how many died during the year, or during the 7-year period. The numbers were almost identical in the 2 groups, because even though the CPAP was more effective, the compliance was much higher with the oral appliances. People found them much easier to use. So I would love to have any questions that you might have. If you are interested in an oral appliance, there are ways to get it covered, at least partially, by medical insurance. It's not considered a dental procedure. It is a dental solution for a medical issue, so it comes under medical insurance. And most medical insurance will provide at least some coverage for oral appliances. So anybody who is concerned about that, that's something that we are very good at handling. And it's not always easy to get through these pathways of medical insurance, but we usually do find a way with that. So
I have a question. I
Yes.
had a non-malignant brain tumor. It was acoustic schwannoma, and I had it removed. And the neurologist told me that, and this is one reason why I got checked, that a lot of people that have had that, because of the paralysis you get, which I have on this side, can cause that.
Well, anything that is going to interfere with the proper functioning of the muscles that hold the airway open is it's going to have an influence on that. Okay, so again, we would have to look at your particular situation, but I would imagine that creating a device that will help to hold your tongue away from the back of your throat.
Now, are you saying that this keeps your mouth shut, like you can't open your mouth when you're wearing it? The tap appliance does hold your teeth together. Okay, the Herbst appliance does to a more limited degree. You can open your mouth a little bit with the Herbst. Because what happens if you're, like, I'm a mouth breather because I have allergies.
You can still breathe through it.
You can still? Because I have allergies and my nose is always, I use nasal sprays that, for allergy, and I still.
Look at all that open space with the tap there.
Because that would be my question, because I know
Yeah.
my nose is always stuffy. I can't use it.
Right, yeah. Nose breathing is actually more healthy than mouth breathing, but for those who can't breathe through their noses, none of these appliances
See, that's why
have
this
a problem
thought of
with
a
that.
CPAP scares me.
Mm-hmm.
Because if you were shooting air in when I'm trying to get it out of there,
Well,
or get it
usually
whatever, I don't know.
the machines are usually set so that you can inhale and exhale, and there's even one that's I believe the AutoPAP changes the pressure of the air that's going in and out depending on whether you're inhaling or exhaling. So that's usually not an issue.
He put it on. Oh, I'm wearing this. I'm choking. Like he was. I know when he first got it. He's used to it now.
Mm-hmm. Mm-hmm.
But,
there's always a period of adjustment, whatever solution you're going to use, whether it's the CPAP or an oral appliance. But the main thing is to do something, because this, one of the reasons why I spend so much time talking about the negative health consequences of obstructive sleep apnea is because there's so many of them. Okay, we've known for years that diet affects health. We've known for years that exercise affects health. Sleep is rapidly becoming that third pillar of health, that having proper sleep, what we call proper sleep hygiene, and being able to go through the different, cycles of sleep, the different levels of sleep, being able to have sufficient REM sleep. That's very, very important for a person's health, both, the health of the body and the health of the mind. There are all kinds of, there's all kind of evidence coming out what the body does during sleep. People think of sleep as like, well, nothing happens during sleep. You're just asleep. Okay? It's a very dynamic process that the body is doing all these things that are, repairing itself from the ravages that we put them through during the day. So having great sleep is so important for a person's health. And being able to breathe properly and have proper oxygen during that is, there's no way that you could be healthy without good sleep and good breathing. So,
Makes sense.
doesn't it?
I have this Fitbit,
Uh-huh.
and it tells you about your. And I was
That's
looking
actually very controversial.
well,
whether
if it
The
does or not.
accuracy, the
I
accuracy of
noticed
the
that the
Fitbit.
deep sleep I'm not in very much on this thing.
Well, that
Is that not accurate?
that's like I said, that's very controversial. Okay, there is not currently a device that can accurately measure that kind of thing 100% of the time. That you can wear on your wrist.
How do you get the at-home thing? Like without going?
You would do it through a sleep center.
Oh, so
Okay.
you can get that there.
Yes, and I have relationships with 2 sleep centers. They're both very, very good. They have excellent sleep physicians there, excellent sleep techs. They can, if you want to do in lab, they have great in-lab facilities, and they also have home sleep testing devices
How
as
long
well.
do you? Like I know when I did it in the lab, I couldn't sleep like I normally would.
Mhm.
Like I was up and down and up and down.
Well,
just because I wasn't at home in my bed with my pillow, that kind of thing.
Well, the other thing is, okay, I hear that a lot, but when a patient tells me that, and then I look at their sleep test,
They were sleeping.
they were sleeping. They may not know it. They may feel like they got up and down 100 times, but when you look at what is actually on the sleep test,
it is enough to.
it depends, okay? I mean, there's some patients that, they slept 2 hours there. That's not enough to, do a diagnosis. You need at least, ideally, we like to have at least 6 hours of sleep to do a diagnosis. Okay, so, and that's why a lot of times they'll do, consecutive nights because it's so difficult the first time. And even when you go there, the first night just to be tested, just the fact that it's your first night there, there's actually something that's called the first night, syndrome, or the first night. There's a term for it. Like, even when you go away, like on a vacation, and you're in the hotel, and the first night you have a harder time sleeping than you do the rest of the nights. It's because you're in a strange place. That's actually been documented, that there's a condition where it's harder to fall asleep the first night.
I don't even go into that.
So very often they'll have you do 2 nights in the sleep lab so that they can get more accurate data for that. So
I have a question.
yes.
And this, for anybody who's listening, and for you guys, this is a question I posed to Dr. Nathanson that affects my personal life. My boyfriend snores. I've insisted on him getting a sleep study. His brother gave him his CPAP device from his own sleep study. So the question we've been asking each other is, can my boyfriend then use his brother's CPAP?
It's not advisable. Using somebody else's CPAP would be like using somebody else's medication, which I know people do, but you're not supposed to do that. A medication is prescribed for a specific individual for a specific condition. It's the same thing with the CPAP. The CPAP, there are all different masks that can be used. The pressure needs to be set properly. There's so many variables in successfully having a CPAP used that, what's good for one person very often is not good for another one. So no, I would not advise having a person use another person's CPAP. They can go to a sleep center. Maybe they can bring that CPAP with them and see if it's one that they might be able to use. But a qualified sleep technician or a sleep physician needs to dispense that CPAP. I cannot emphasize that enough. It can be very dangerous for him to use the CPAP when it's not set at the proper the proper pressure. And besides, if somebody has already used that CPAP,
Gross.
you have to make sure that everything is cleaned properly. I wouldn't even use somebody else's toothbrush, let alone their CPAP. Okay, but it's kind of like the same thing.
So, in following up to that, the question I was asked after I gave this information back to them was, how can you have too much oxygen?
I'm glad you asked that question. A CPAP does not dispense oxygen. A CPAP dispenses compressed air. The compressed air is what holds the airway open so that you can breathe properly and get oxygen. That's a very, very common misconception. A CPAP does not blow oxygen. There may be some that are set up in conjunction with an oxygen tank to provide better oxygenation, but the purpose of a CPAP is not to provide more oxygen. It is to provide compressed air. That's what the C of CPAP is, compressed. Okay. I'm sorry, it's continuous positive air pressure. I was wrong about that. Can you erase that? Continuous positive air pressure. So yeah, it's live. Okay. So no, but it is compressed air, and so it's not oxygen, and so that's a very common misconception, and it's certainly not a reason for somebody to use somebody else's CPAP. So okay. Well, thank you all for being here. I hope you all learned something. We're here to help you if you would like, to investigate the possibility of getting screen tested, being, routed for, either a CPAP or an oral appliance. If you're a candidate for an oral appliance, we'd really love to help you with that. And we look forward to hearing from you soon. Have a good night.